So in 2011, BBC Panorama did a documentary on Winterbourne View. And that was a locked service for people with a learning disability and autistic people. And that documentary identified horrific systematic abuse within that hospital. And that created shockwaves really across all systems. And as a response to that, the government nationally introduced a programme to make sure that people were in receipt of the right care and the right treatment at the time when they needed it, and to make sure that we reduce the length of stay for people that did need to go into hospitals. To make sure that we've done everything we can to make sure that somebody can remain in their own home, in their community, and that we would only be admitting people to hospital that absolutely needed to be there.
It makes me feel quite frightened and nervous really, because I don't really know anybody really, and I can't go out and do the things that I enjoy doing. I do feel really sad that I haven't got that independence anymore. I do really want to have that independence back.
So they introduced care and treatment reviews for adults, and then for people under the age of 25, they introduced care, education and treatment reviews.
Part of the focus of the CTR is to look beyond the medical model, the person being in a hospital and receiving treatment. It's about looking towards discharge, a life beyond hospital, looking at the whole person, not just the illness. The panel members are independent of the multidisciplinary team, and that's really important because we can ask the difficult questions that employees of the hospital might not be able to.
As an independent panel and as chair of that panel, the day would look at starting to get an overview of that person's needs, their history, relevant information that has led to the crisis situation. We would have opportunity to do that through reviewing care plans, risk assessments, positive behaviour support plans and health action plans. As the chair of the CTR, I would have ensured that we had informed consent from the person. If the person wasn't able to make an informed decision and lacked capacity, then the MDT would have supported that person with a best interest decision.
That panel also consists of 2 additional members. One person is somebody with lived experience, so an expert by experience. If you've got a young person that's in crisis, their family are in that crisis with them, trying to support and trying to understand and navigate their way through a really complex health and care system. To have somebody with lived experience of being a family member is really beneficial. If somebody is an inpatient in one of our hospitals, then we would want to match them with somebody who's had that similar experience, so somebody with a learning disability or an autistic person, to make it easier to navigate their way through their CTR.
Things that I look out for personally as an expert by experience are if there are any gaps in the information that we've been given. That can be around education or the support that they've had or lack of support that they've had prior to the reason that we're doing the CTR on that day. I like to find out about the person's family circumstances. Not everybody has got family around them, and not everybody wants their family to be involved in their care, but if they do, then it's a real priority that that is established as soon as possible. All of this information gives us a picture of what this person's life is currently like. Is the person safe? What's their care and treatment looking like so far? What do they want for their future?
And the other person is a clinical expert, so that's somebody that's been a clinician or currently is a clinician within those services that has a good understanding of the pathways and the way that hospitals work and a good oversight of the MDT.
I am confident and able to ask questions and look at the person's holistic needs, making sure that the person is equal and central in the decision-making process and the whole of the treatment plan, and that the MDT and each professional alongside the patient and the family have their voices heard as equal partnerships and collaboration. From the start of somebody's admission into hospital, we need to consider whether a person needs to be in hospital, what is the least restrictive option for that person, and my role is to be creative in the discussions during admission, throughout treatment planning, to always have discharge at the heart of the discussions and to make long-term plans for that, so that the person lets us know how they want their discharge plans, and the MDT can work with that person or patient to make sure that that happens in a timely manner.
Once we had completed that, we would take a small break to reflect on the information that we'd read and learnt. I would make prior arrangements as the chair as to when we would meet the person who the CTR is for, their parents or carers, and the MDT. We would meet the MDT when we would gain more information around the current needs and level of risk.
So the multidisciplinary team, or the MDT, will consist of all of the healthcare professionals and other professionals that are integral to that person's care. The MDT have a responsibility to the person with learning disability and or autism to make sure that their needs are met holistically, so considering all of their health needs, their social care needs, making sure that those are reviewed regularly and that that's thorough and that everyone's involved who needs to be involved. I would have a role in supporting the person with learning disability and or autism to understand the process of the CTR, why the CTR might need to happen, understanding who their key contacts within the MDT and the CTR process are, understanding what treatments are available to them and being offered to them, and whose responsibility it is for making sure that those treatments take place.
The responsible clinician would lead the multidisciplinary team to make sure there's effective delivery of mitigating any risk for that individual and making sure there's a full understanding around their mental health and physical health needs. The responsible clinician would most likely be a psychiatrist, and a key part of this role is to oversee somebody's medication and review it in line with STOMP and STAMP guidance. This will ensure that people have effective treatment and to also ensure that they're not over-medicated. Another key part of this role is to make sure they liaise with other professionals and health professionals to make sure the person is kept physically well.
Within the CTR meeting, the social worker will share information about the individual's current social care package and support plan and whether that appears to be working for them. The social worker will also advise about any further support that may be available from social care.
Once we have taken the opportunity to have those reflection breaks in between seeing the MDT, the person, parents and carers, we would then have a more prolonged period of time, up to an hour, to reflect and to gather all of that information to formulate the action plan. And then we have the opportunity at the end of the day to feed that back to the MDT, to the person, parents and carers, to ensure that they can start any urgent actions that are required.
For people under the age of 25, if they're on our remission avoidance pathway and they're on our dynamic support register, they would be eligible to have a key worker. The key worker is really important because they get to know the person, their family and everybody that's working around that person to support that admission avoidance, to make sure that we're doing all we can for that individual to remain in the community with their family or in their own home.
During the CTR, I will help the child or young person to make sure that the panel understand their thoughts and feelings, their wishes around discharge or admission avoidance, and to make sure that their voice is being heard. At the end of the CTR, once the action plan has been made, it is my responsibility to make sure that all professionals and support networks are aware of the actions and that they're completed within a timely manner.
It also leads us to think about reasonable adjustments as well that we might want to make sure that that person themselves can be part of their care and education and treatment review, that they understand the information that's shared with them, that that's in an accessible format. We're happy and really flexible around making reasonable adjustments. It's just really important that the person is able to be part of their CTR or their CETR.
The reason why I enjoy doing this is because it puts the person at the heart of decisions about their life. It's their chance to have their say. They can be in the panel, which is really important. It's nice if they can attend, because then we can really hear their point of view. They are the most important person in this process.
I think without the support we had in these meetings to speak up for her and to make Georgia's voice heard of what she would want, we wouldn't have got the same outcomes.
My advice to anyone out there who is struggling or in any situation like I have been, I would recommend talking to the CTR because they have helped me, and I'm sure they would help you too.